Can you tell me about a time when you successfully contributed to a multidisciplinary team?
I was looking after an elderly gentleman who had suffered a stroke. He was medically stable, but very weak. The physiotherapist felt he was ready for more intensive rehabilitation. However, the patient refused to get out of bed and became quite tearful whenever we tried. I realized we needed a different approach as a team. My task was to find a way to motivate him and help him engage with the therapy plan so he would not lose further mobility. I spoke to him quietly during his morning wash, using simple, reassuring words. I discovered he was terrified of falling again and felt he had become a burden. This was the real barrier, not laziness or stubbornness. I brought this information to our next team huddle, which included the physiotherapist, the occupational therapist, and the consultant. We made a shared decision to involve his daughter, who visited every evening. I suggested she be present for a short physio session. I coordinated with the physiotherapist to schedule a time that suited the family. The result was wonderful. With his daughter holding his hand and cheering him on, he took 3 steps that very afternoon. His whole demeanor changed. By sharing the psychological insight I had gained at the bedside, the entire team could adapt our care plan to address his fear, not just his physical weakness. This experience reinforced my belief that a nurse's role in the multidisciplinary team is to be the voice of the patient's hidden concerns.
How do you ensure effective communication with patients and their families?
For me, effective communication begins with treating every interaction as a two-way process. I listen before I speak. I remember a situation with an elderly woman who was ready for discharge after a hip replacement. Her son arrived looking very anxious. He immediately started questioning why she was being sent home so soon. He felt she was not safe. I could have just repeated the discharge plan to him, but instead, I asked him to sit down and tell me his specific worries. He revealed that he lived 2 hours away and could not visit daily. He was terrified of her falling alone at night. My task was to address his fear while ensuring the patient's autonomy was respected. I used plain, jargon-free language to explain her mobility assessment. I showed him the occupational therapy notes, which confirmed she could safely use the commode and walk with a frame. I involved the patient herself, who clearly stated she wanted to go home. Then I connected him directly with the social worker, who arranged a personal alarm system and a referral to the community care team for daily check-ins. Before he left, I gave him my handover sheet with a direct ward phone number, so he could call to clarify any doubts later. The result was a visible shift in his posture. His shoulders relaxed. He thanked me and said he felt heard. I learned that true communication is not about giving a perfect speech. It is about creating space for questions, showing empathy, and then bridging the gap between clinical language and a family's emotional reality.
Describe a time you had a conflict within the healthcare team. How did you handle it?
I recall a situation on a busy medical ward involving a disagreement with a junior doctor about a patient's fluid management. My patient was an elderly man with heart failure, admitted with a chest infection. He was already on a strict fluid restriction. During the ward round, the doctor prescribed an intravenous antibiotic but ordered it to be diluted in a large volume of fluid over several hours. I could see immediately that this would push the patient well over his daily limit and risk pulmonary edema. I did not challenge the doctor in front of the patient or the team. I waited for a private moment and approached him calmly. I said something like, "I wanted to discuss Mr. Murphy's 4 antibiotics. I am concerned the dilution volume might overload him, given his fluid restriction. Could we check this together?" He initially seemed defensive and said it was the standard dilution. I acknowledged his point, but then showed him the patient's fluid chart and his input-output balance for the last 24 hours. I also pointed to the cardiologist's clear instruction. I suggested we contact the pharmacist for advice on a more concentrated preparation. He agreed to make the call. The pharmacist confirmed that a smaller volume was possible. The prescription was changed. The patient received his treatment safely with no fluid overload. Afterwards, the doctor thanked me for catching it. What could have become a heated argument was handled quietly through factual evidence and by focusing on the shared goal, which was patient safety. I learned that managing conflict is about choosing the right moment, using evidence rather than emotion, and framing it as a collaborative problem rather than a personal criticism.
How do you establish priorities to meet deadlines? Give an example of when you had several demands on your time.
I establish priorities using a simple clinical triage system in my head. Patient safety always comes first. A sudden change in vital signs will always beat a routine task. After that, I look at time-sensitive duties like 4 antibiotics or preoperative checks. Finally, I schedule the tasks that can be shifted without harm, such as routine documentation or stocking the trolley. But planning is only half the story. The real skill is staying flexible. I can give you a clear example from a morning shift. I had 6 patients to care for. My plan was to start with the post-operative gentleman in bed 2, who needed his 4 pain relief and wound check. Almost immediately, the healthcare assistant called me to bed at 5. The patient there had a sudden spike in temperature and was shaking with rigors. His early warning score had jumped. At the same time, the discharge coordinator phoned the ward. She needed a final set of observations for a patient in bed 1 before transport could arrive. The challenge was 3 urgent demands hitting me at once. I had to make quick decisions. I asked the healthcare assistant to stay with the unstable patient in bed 5 and record a full set of vitals. I then delegated the discharge observations to a competent colleague. I explained exactly what was needed and confirmed she was free to help. This freed me to immediately assess the deteriorating patient myself. I started the sepsis screening tool and escalated to the medical team. Once the doctor arrived and treatment was underway, I then circled back to my post-operative gentleman for his pain relief. He understood the short delay when I briefly explained there had been an emergency. By delegating safely, triaging clinically, and communicating clearly, I met all 3 demands without compromising anyone's safety.
How do you prioritize care when managing multiple patients?
My approach to prioritizing care is grounded in clinical risk assessment. I use the ABC principle as my compass. A threat to an airway, breathing, or circulation always comes first. After that, I assess pain, safety risks like falls, and time-critical medications. But I also know that on a real ward, priorities can shift in seconds. I remember a late shift when I was responsible for 7 patients. My initial plan was to start the evening drug round. Before I could begin, 3 things happened almost simultaneously. The call bell rang for a patient who had just returned from surgery and was in severe pain. A relative approached me at the nurse's station, very distressed, saying her mother in the side room seemed more confused than usual. At the same moment, I noticed the cardiac monitor of the patient in bed 4 was showing a fast, irregular rhythm. I made an instant decision. The cardiac arrhythmia was potentially life-threatening, so that was my first priority. I went straight to that patient and assessed him. He was conscious but dizzy and his blood pressure was low. I called for the senior nurse to inform the doctor immediately. I then asked a trusted colleague to give the post-operative patient his prescribed analgesia. I knew she was competent and the medication was already checked. Finally, I approached the distressed relative. I asked her to sit with her mother while I quickly checked the patient's baseline observations. I discovered the confusion was new and likely linked to a urinary tract infection. I reassured the daughter that I would escalate this urgently once the cardiac patient was stable. By delegating the task that another nurse could safely do, addressing the clinical emergency myself, and then returning to the relative, I ensured no one was neglected. The key was staying calm, thinking logically, and using my team wisely.
How do you ensure high-quality patient care and maintain accurate documentation?
I view documentation as a direct extension of the care I provide. It is not a separate chore to be done later. My personal rule is to document as close to the point of care as possible. If I do a wound dressing, the notes are written immediately after, not 3 hours later at the end of the shift. Memory fades and details blur. Accuracy depends on immediacy. I can share a specific practice that guides me. I once cared for a patient who had developed a pressure ulcer during a long hospital stay. The tissue viability nurse had given very detailed instructions on the dressing regime. I knew this was not a routine wound. So after every dressing change, I wrote a focused entry. I did not just write dressing changed. I described the wound bed, the size, the exudate color and amount, and the surrounding skin condition. I named the exact dressing products used. This level of detail was critical. It allowed the next nurse to see immediately if the wound was improving or deteriorating. It also provided an audit trail for the specialist team. Quality care and good documentation feed each other. A meticulously filled fluid balance chart lets me spot early signs of dehydration or fluid overload and act quickly. A correctly completed early warning score chart is what triggers a timely medical review. I always ask myself a simple question. If I had to defend my actions in a legal setting, would my notes be clear and complete enough? This mindset keeps my standards high. I believe that accurate documentation is a fundamental act of patient advocacy and professional accountability.
How do you manage stress in a fast-paced nursing environment?
I have learned that stress itself is not the enemy. It is a normal response to a demanding environment. The danger is unmanaged stress, which can lead to burnout or clinical errors. My personal strategy has 3 layers. I control what I can during the shift. I decompress after it, and I maintain my resilience outside of work. During a shift, my main tool is structured thinking. When the ward becomes chaotic with multiple call bells and new admissions, my instinct used to be to panic and rush. I learned the hard way that rushing leads to mistakes. Now, I force myself to pause for 10 seconds. I take a slow breath. I mentally list the top 3 clinical priorities in that moment. This tiny pause helps my brain switch from reactive panic to logical problem solving. It sounds small, but it transforms my focus. I recall one particularly overwhelming night shift. We were short-staffed, a patient was actively deteriorating with sepsis, and 2 new admissions arrived from the emergency department at the same time. I felt my heart racing. I stepped aside for a moment, took that breath, and quickly triaged the workload. The septic patient was my priority. I asked a colleague to settle the more stable admission. I communicated clearly to the nurse in charge that we needed extra hands for the second admission. Breaking an overwhelming situation into clear, sequential tasks immediately reduced my sense of chaos. After the shift, I did not carry the stress home. I talked through the events with a trusted colleague for a few minutes, which acted as an informal debrief. Outside of work, I protect my sleep and walk outdoors daily. These habits build a foundation so that when high-pressure moments come, I have the reserves to meet them calmly.
Tell us about a time you advocated for a patient.
I believe advocacy is a core nursing duty. It means speaking up for a patient when they cannot speak for themselves, even when it feels uncomfortable. I recall a situation with a middle-aged woman who was post-operative after major abdominal surgery. She had a history of chronic pain and was on a complex analgesic regimen at home. In the hospital, her usual medications were not fully prescribed. By day 2, she was in agony. She was too exhausted and intimidated to challenge the doctors directly. She told me she felt like nobody believed her pain was real. My task was clear. I had to bridge the gap between her suffering and the medical team's awareness. I first conducted a thorough pain assessment using the validated pain scale our hospital uses. I documented the exact score at rest and on movement. I also noted her vital signs. Her blood pressure and heart rate were elevated, which aligned with uncontrolled pain. Armed with this objective data, I approached the surgical registrar. I used the ISBAR communication tool. I identified myself, stated the patient's situation, and gave the background of her chronic pain history. I presented my assessment findings and then made a direct recommendation. I asked for a review by the acute pain service and for her regular baseline analgesia to be restored alongside the post-operative regime. The registrar initially suggested we just continue as planned. I respectfully pushed back, stating the current plan was clearly not working and the patient was deteriorating psychologically. He agreed to review her. The pain team adjusted her medications that afternoon. Within hours, she was mobilizing gently and her mood transformed. She later squeezed my hand and thanked me for believing her. Advocacy, for me, is about using clinical evidence to give a voice to the patient's experience.
How do you manage a deteriorating patient?
My approach to managing a deteriorating patient is structured and systematic. I use the ABCD framework as my mental checklist. It ensures I do not miss anything critical when the pressure is high. I can describe a real situation from a night shift. I went to do routine observations on an elderly gentleman who was admitted with a urinary tract infection. He had been stable during the evening. When I walked in, I immediately noticed he looked different. He was pale, slightly confused, and his breathing seemed shallow. I checked his vital signs. His respiratory rate was 28. His oxygen saturation had dropped to 91%. His blood pressure was low, and his temperature was spiking. His early warning score had triggered a high-level alert. My first action was to stay with him and call for help. I pressed the emergency buzzer to alert the nurse in charge. While waiting, I started the ABCD assessment. Airway was patent, but he was too weak to cough effectively. Breathing was the immediate problem. I applied high-flow oxygen via a non-rebreathe mask and sat him upright. Circulation assessment showed a thready pulse and cold peripheries. I inserted a new 4 cannula and began drawing blood for cultures and lactate as per our sepsis protocol. I also started a cautious fluid challenge as directed by the sepsis guidelines. Disability check showed he was now only responsive to voice. I measured his blood glucose, which was normal. I exposed him briefly to check for any rashes or sources of infection, and then covered him quickly to maintain his dignity and temperature. When the doctor arrived, I gave a clear ISBAR handover. I reported the time I found him, his vitals, the actions already taken, and my concern that this was urosepsis. The doctor was able to prescribe 4 antibiotics immediately because the groundwork was done. The patient was transferred to the high-dependency unit within the hour. The key was following the ABCD drill calmly, starting treatment without waiting for a doctor, and communicating with absolute clarity.
How do you ensure safe medication administration?
Safe medication administration is a responsibility I take extremely seriously. My practice is built on a strict, unbreakable routine. I follow the 10 rights framework for every single patient, every single time. There are no exceptions and no shortcuts. My process starts before I even touch a medication. I prepare myself mentally. I avoid distractions, and I do not engage in casual conversation during a drug round. I go to the trolley, and I perform my first check against the prescription chart. I verify the patient's name, the drug, the dose, the route, and the time. The second check happens when I take the medication out. I read the label carefully and confirm the expiry date. If it is a controlled drug, I ask a second nurse to witness the entire process. The third and most crucial check is at the bedside. I ask the patient to state their full name and date of birth. I never say, "Are you Mary?" because a confused patient might just nod. I then explain what each medication is for. This invites the patient into the safety net. I remember a specific incident where this practice caught a serious error. I was about to administer a beta blocker to a patient. I told him it was for his blood pressure. He looked puzzled and said he did not take blood pressure tablets at home. I stopped immediately. I rechecked the chart and realized the medication was prescribed for the wrong patient's bed. The prescription had not been updated after a bed move. I withheld the drug and escalated the error. No harm reached the patient. I also ensure I document immediately after administration. I never sign the chart before the patient has swallowed the tablet. This prevents double dosing. I also monitor the patient for any reactions, especially after for medications. For me, safe medication administration is a sacred trust between the nurse and the patient. Breaking the process, even once, is never worth the risk.
How do you prevent infection in clinical settings?
Infection prevention and control is not a standalone task for me. It is a mindset I carry into every single patient interaction. I ground my practice in the standard precautions, which are the foundation of safe care. Hand hygiene is the most powerful weapon. I follow the World Health Organization's 5 moments of hand hygiene religiously. Before touching a patient, before a clean procedure, after body fluid exposure, after patient contact, and after touching the patient's surroundings. I am not casual about this. I use the proper technique, covering all surfaces of my hands, for the full duration. I can give you a concrete example of how this mindset translates into action. I once cared for a patient with a confirmed Clostridium difficile infection. She was in a single-sided room. The challenge was preventing the spread of spores to other vulnerable patients on the ward. Soap and water were mandatory because alcohol gel does not kill C. difficile spores. I ensured that outside her room, clear signage indicated the required precautions. I wore a disposable apron and gloves every time I entered. I removed them inside the room, immediately before exiting, and washed my hands thoroughly with soap and water at her sink. I also educated the patient's family, who were anxious. I showed them gently how to put on and remove the protective equipment. I explained why they must not visit the shared day room with her. Beyond this, I apply the principles of aseptic non-touch technique for any invasive procedure, like wound care or catheter insertion. I treat every patient's environment as potentially contaminated and keep surfaces clean and clutter-free. I also see my role as a team educator. If I see a colleague forget hand hygiene, I give a quiet, friendly reminder. Infection control works when every single person is committed. It is about protecting the most vulnerable patient in my care.
How would you handle witnessing unsafe practice by a colleague?
This is a challenging situation for any nurse. Patient safety must always be the priority, but the way we handle it with a colleague matters greatly. I would follow the principles of duty of candor and professional accountability. I can describe an incident I witnessed. A junior nurse was about to administer an intravenous antibiotic to a patient. I noticed she had not completed the proper checks. She did not verify the patient's identity against the wristband, and she had not flushed the 4-line to check patency. She was rushing because the ward was extremely busy. The immediate risk was clear. An incorrect patient identification could lead to a serious drug error. An unflushed line could mean the drug infiltrates into tissue. My first action was direct but respectful. I approached her quietly and said in a low voice, "Hold on a moment. Let me just double-check that with you." I did not shout or embarrass her in front of the patient. I guided her back to the basic steps. I asked the patient to state his name and date of birth. We checked the wristband and the prescription chart together. Then I asked her to flush the cannula first. She complied. The flush revealed the cannula was indeed blocked and the medication would not have gone into the vein. The patient was protected. After the drug round, I asked to speak with her privately in the staff room. I did not accuse or attack her. I said, "I noticed you seemed very rushed earlier. Is everything okay?" I was concerned because we nearly missed the blocked cannula. She broke down and admitted she was overwhelmed with her workload. I listened. I then gently reminded her that no matter how busy we are, the safety checks are non-negotiable. I offered to help her organize her tasks for the rest of the shift. I also suggested she should feel safe to speak to the nurse in charge if her workload becomes unmanageable. The outcome was positive. She thanked me for stopping her and for not reporting her formally. She just needed support and a calm reminder. If it had been a repeated or intentionally unsafe act, I would have escalated to my manager without hesitation. My guiding principle is to support the colleague to improve, but never at the cost of patient safety.
How would you handle a distressed or challenging patient?
I have learned that distressed or challenging behavior is often a form of communication. The patient is trying to express an unmet need, a fear, or physical discomfort. My first job is not to react. It is to understand. I remember a gentleman in his late 70s who was admitted with pneumonia. He became verbally aggressive every time anyone tried to take his blood pressure or help him with personal care. He would shout and wave his walking stick at the staff. The other nurses were frightened of him. I could see the situation was escalating, and his essential care was being delayed. My approach was to step back and find the root cause. I checked his medical history and spoke quietly with his daughter during visiting hours. I discovered he had been a prisoner of war in his youth. Being approached suddenly by strangers in uniforms triggered a deep trauma response. He was not an aggressive man. He was terrified. My task was to build a sense of safety so we could deliver his care without distress. I decided to change our entire approach. I asked the team to assign the same 2 nurses to him consistently so he would see familiar faces. I always approached him from the front where he could see me clearly. I never rushed at him with equipment. I sat at eye level and spoke in a calm, low voice. I explained every single step before I touched him. I gave him simple choices, like which arm to use for the blood pressure cuff. This gave him a sense of control he had lost. The result was gradual but profound. Over 3 days, his aggression stopped. He began to trust us. He even joked with me one morning. By adapting the environment to his psychological needs instead of forcing him to comply, we transformed his hospital experience. It taught me that patience, empathy, and a little detective work can defuse the most challenging situations.
What are the key differences in clinical presentation and oxygen therapy goals for a patient experiencing a type 1 versus a type 2 respiratory failure secondary to a COPD exacerbation?
The key difference between type 1 and type 2 respiratory failure lies in the carbon dioxide level in the blood. This drives completely different oxygen therapy goals. I will explain both clearly. Type 1 respiratory failure means the patient has low oxygen in the blood, but their carbon dioxide level is normal or low. A COPD patient might present like this during a mild to moderate exacerbation. They will be breathless, their respiratory rate will be fast, and their oxygen saturations will be low. They might look anxious and use accessory muscles to breathe. Because there is no carbon dioxide retention, my goal with oxygen therapy is straightforward. I aim to bring their saturations up to the target range of 88 to 92%. I can use a higher concentration of oxygen initially if needed, guided by the early warning score and the prescription. Type 2 respiratory failure is far more delicate. This means the patient has low oxygen and high carbon dioxide. This happens in advanced COPD when the lungs can no longer effectively remove carbon dioxide. The clinical picture changes. The patient may still be breathless, but they might also have a bounding pulse, warm extremities, a fine tremor, and confusion or drowsiness. These are signs of carbon dioxide narcosis. This is where the oxygen goal becomes absolutely critical. If I give too much oxygen, I can suppress their hypoxic drive to breathe, causing their carbon dioxide to rise even further and potentially leading to respiratory arrest. So my goal shifts. I must give controlled, low-dose oxygen, usually via a Venturi mask at 24 or 28%, to keep saturations precisely between 88 and 92%. I monitor them extremely closely with repeated arterial blood gases. The core difference is that type 1 needs more oxygen safely, while type 2 needs carefully titrated, lower oxygen to avoid knocking out their drive to breathe. Recognizing this difference at the bedside is a life-saving nursing skill.
How do you prioritize workload on a busy ward?
Prioritizing workload on a busy ward is about making fast, safe decisions based on clinical need, not just racing through a to-do list. My mental framework is simple. I divide everything into 3 categories: tasks that are immediately life-threatening, tasks that are time-critical, and tasks that are important but can be safely delayed. This stops me from being pulled in every direction at once. I recall a particularly chaotic morning shift that tested this approach. I was caring for 5 patients. My planned workload for the first hour was to administer 4 antibiotics to the gentleman in bed 3, do a complex wound dressing for the lady in bed 1, and then catch up on the fluid balance charts. Before I could start, the healthcare assistant called me urgently. The patient in bed 4 had just vomited a large amount of fresh blood. At the same moment, the pharmacist arrived needing a medication reconciliation for a new admission, and the relatives of the patient in bed 2 were waiting to speak to a nurse about his discharge plan. My brain instantly triaged the demands. The hematemesis was a potential life-threatening emergency, so it jumped to the top of my list. I asked the healthcare assistant to stay with that patient and get a full set of vital signs while I grabbed the emergency trolley. I quickly turned to the pharmacist and said, "I have a clinical emergency. Can I find you in 15 minutes?" She understood completely. I then briefly approached the relatives and said, "I am so sorry. I have to attend to an emergency. Please wait in the day room, and I will come and speak to you as soon as it is safe." I did not ignore them. I acknowledged them and set a clear expectation. I managed the bleeding patient, escalated to the medical team urgently, and stabilized him. Once he was safe and the doctor was present, I handed over and stepped away. I then completed the medication reconciliation with the pharmacist because that was now the next priority to ensure the new patient's safety. The wound dressing could wait a little longer without harm. Finally, I went to the waiting relatives. I sat with them, apologized for the delay, and gave them my full attention. The key was constant clinical triage, clear communication with everyone involved, and never mistaking a calm request for an urgent need.
A patient's face is drooping on one side, their speech is slurred, and you notice one-sided arm weakness. What tool is used to recognize this condition?
The tool used to recognize this condition is the FAST acronym. It stands for face, arms, speech, and time. This is a simple and effective pre-hospital screening tool that anyone can use, including healthcare professionals at the first point of contact. Let me walk you through how I apply it at the bedside. Face means I ask the patient to smile, and I look closely for any asymmetry. One side of the mouth might droop or not move at all. Arms means I ask the patient to raise both arms in front of them and hold them there. I watch for one arm drifting downwards or being unable to lift at all. This signals motor weakness. Speech means I listen to the patient talk. I might ask them to repeat a simple sentence like, "The sky is blue." I listen for slurred words, jumbled speech, or a complete inability to speak. The final letter T for time is the most critical. It is a reminder that if I see any of these signs, I must act immediately. Time is brain. I would note the exact time the symptoms began or the last time the patient was seen well. I then call the emergency stroke team without delay. I also check the capillary blood glucose immediately because hypoglycemia can sometimes mimic a stroke. My next step is a full set of vital signs and a focused neurological assessment using the Glasgow Coma Scale. While waiting for the team, I keep the patient nil by mouth because swallowing may be compromised. I stay calm and reassure the patient, explaining simply what is happening. Early recognition with the FAST tool and rapid escalation is what gives the patient the best chance of receiving thrombolysis or thrombectomy within the narrow treatment window.
Describe the nursing management and immediate first-line investigations for a patient presenting with a sudden, severe headache, described as a thunderclap, with associated photophobia and neck stiffness.
A thunderclap headache with photophobia and neck stiffness is a red flag presentation that I treat as a medical emergency. The most urgent concern is a subarachnoid hemorrhage, but meningitis is also a possibility. My immediate nursing management follows the ABCD framework while I prepare for urgent investigations. I would first assess the airway. It is usually patent if the patient is talking, but a sudden drop in consciousness can change that quickly. I then assess breathing and apply oxygen to maintain saturations above 94%. Circulation comes next. I insert 2 wide-bore intravenous cannulas and take blood samples. I draw a full blood count, a coagulation profile, and urea and electrolytes. I also measure the blood glucose to rule out hypoglycemia as a cause for any altered consciousness. Disability assessment is crucial. I check the Glasgow Coma Scale and the pupil size and reaction. Any drop in consciousness or a blown pupil would terrify me, as it signals rising intracranial pressure. I would escalate immediately to the medical team and the critical care outreach nurse. Pain management is a key part of my role. Severe pain raises blood pressure, which can worsen any bleeding. I administer prescribed analgesia promptly. I also dim the lights to minimize the photophobia and keep the environment as calm and quiet as possible. I maintain strict bed rest and advise the patient to avoid any straining, as this can spike intracranial pressure. The immediate first-line investigation is an urgent non-contrast CT scan of the brain. This can identify a subarachnoid bleed. If the scan is negative but suspicion remains high, a lumbar puncture will follow to look for xanthochromia or signs of infection. I prepare the patient for transfer to radiology. I never leave them alone. Continuous neurological observation every 15 minutes is essential to catch any deterioration early. My role is to act fast, support the patient, and provide the medical team with the information they need to make rapid decisions.
A patient with a gram-negative infection develops hypotension, tachycardia, and mottled skin. What type of shock is this? Besides 4 antibiotics, what is the first-line intervention in the sepsis bundle?
This clinical picture strongly suggests septic shock. The gram-negative infection is the trigger. The bacteria release endotoxins into the bloodstream. which causes massive vasodilation and the leakage of fluid from the blood vessels into the tissues. The hypotension and tachycardia are the body's desperate attempt to maintain cardiac output. The cool, mottled skin tells me the peripheries are shutting down because blood is being diverted to the vital organs. This patient is in a life-threatening state. Besides administering intravenous antibiotics, the first-line intervention in the sepsis bundle is to begin immediate fluid resuscitation with intravenous crystalloids. The goal is to restore the circulating volume and improve blood pressure and tissue perfusion. I would follow the sepsis 6 pathway. This means I would take blood cultures and measure a serum lactate before starting the antibiotics. The lactate tells me how severe the tissue hypoperfusion is. I would then start the fluid challenge rapidly. The standard is 30 milliliters per kilogram of crystalloid, often given as a bolus over 30 minutes. I would use a pressure bag to speed up the infusion if needed. While the fluid is running, I am continuously reassessing the patient. I watch the blood pressure, the heart rate, and the urine output. I am also looking for signs of fluid overload, especially in an elderly patient, such as crackles in the lungs or dropping oxygen saturations. I monitor the early warning score closely to see if the patient is responding. Alongside fluids and antibiotics, I also measure the hourly urine output by inserting a catheter. This is a direct indicator of whether the kidneys are being perfused. I also started oxygen therapy to maintain saturations above 94%. The key message is that in septic shock, time matters. Giving the right fluids quickly alongside prompt antibiotics is what saves lives. Every hour of delay increases mortality significantly. My role is to initiate these steps urgently and escalate to the critical care team for ongoing management.
Your postoperative patient is suddenly confused, sweaty, and agitated. Their capillary blood glucose is 2.1 millimoles per liter. What is your priority intervention?
The blood glucose reading of 2.1 millimoles per liter confirms severe hypoglycemia. This is a medical emergency. The brain is being starved of its primary fuel, which explains the confusion, sweating, and agitation. My priority intervention is to restore the blood glucose to a safe level immediately. The patient is conscious, although confused and agitated. This means they still have a protected airway and can swallow safely. The first-line treatment in this case is to administer fast-acting oral glucose. I would give 15 to 20 grams of a simple carbohydrate. This could be 5 dextrose tablets for large glucose sweets or a small carton of pure fruit juice. I avoid anything with fat, like chocolate or biscuits, because the fat slows down the absorption of sugar. I stay with the patient and help them take it orally. If they are too agitated to chew safely, I would switch to a glucose gel squeezed between the cheek and gum. This is absorbed through the oral mucosa. If the patient was unconscious or had a compromised airway, the treatment would be different. I would then need to give intravenous 10% dextrose or intramuscular glucagon, as per the prescription and hospital policy. But in this scenario, the oral route is the fastest and safest option while the patient can still swallow. After giving the glucose, I wait exactly 15 minutes and then recheck the capillary blood glucose. If it remains below 4 millimoles per liter, I repeat the treatment. Once the blood glucose is normalized, I give a longer-acting carbohydrate. A sandwich or a glass of milk with a biscuit works well. This prevents the glucose from crashing again. I also find out why this happened. I check the medication chart. I look for recent insulin doses, missed meals, or excessive fasting before the procedure. I escalate the event to the doctor and document everything clearly. The immediate priority, though, is to rescue the brain with sugar. Without that, everything else is irrelevant.